Shall I start? Yes. Yeah. Hi, everyone. So I'm Dr. Shweta Gupta. I'm coordinating today's webinar, which is by SIG Endometriosis. And we are very lucky to have Dr. Pankaj Talwar sir with us. And also Dr. Shweta will be joining soon. We are also going to have a very interesting talk. And now this our SIG is on endometriosis. So as we all know, endometriosis has a very it is dependent on the endoscopy, not only for the diagnosis and also for the treatment. So we have requested Dr. Kuldeep sir to give a very interesting talk on tips and tricks for endoscopy. So we'll have a first talk then, and thereafter two panel discussions for how to manage both, how to manage the pain as well as how to manage the infertility. So before we start anything, I'm going to request Dr. Pankaj sir to give a short message before we proceed further.
Thank you, Shweta.
Pankaj sir.
Thanks for this opportunity. I feel humbled and honored. And as you guys, as you all know that this is part of our SIG activity, and we have 20 SIGs in our secretariat. So two of very active SIGs are endometriosis and endoscopy. It's like having some fragrance to the rose. Both of them, they have to work together. Without endoscopy, without laparoscopy, endometriosis is incomplete and vice versa. So what, Shweta, thank you so much for taking this lead. And what you have done is that you brought down doyens of both endometriosis and laparoscopy together. And along with that, great congrats for getting Shikha on board. So for everyone to know that today we have this program is being done along with the Northeast chapter, and Dr. Shikha is heading that chapter. And along with that, we have Dr. Kuldeep Jain as he's the mentor of laparoscopic group, and along with him we have Dr. Roy as the mentor of the endometriosis group. Dr. Shweta, for all of you to know, she is the convener. Dr. Parul is the convener of the endoscopic group. So all of them have come down together, and I'm very, very sure that with all the young blood, I can see Shikha there, I can see Mansi there, I can see Soumya there, Sabina there. These people are, you have brought life into it. And I'm very, very sure that by the end of this 1.5 hour session, you'll all go back very, very intelligent and learned. So what is the aim of our SIGs? SIGs was started long time back, and now we have growing in number from say 10 to 15. Now we are at 20 of them. And the aim of our SIGs is to connect all our 4,600 members pan-India together. We have got 29 state chapters. And along with this, we've got a very, very active Young Turks group, which are very keen to learn more about endometriosis and laparoscopy. I'm very, very sure that today's meeting is going to evolve to a very next generation level with Dr. Kuldeep starting his opening batsman today with his talk on endometriosis. And we'll learn from so many panels and young panelists talking about endoscopy and endometriosis. So with this, Shweta, thank you so much for inviting me here. I'm very, very sure that this endeavor of yours, it wasn't easy, Shweta. Getting two SIGs together and getting one chapter together is not easy, and you have done it single-handedly, definitely with the whole team together. With the blessings of Dr. Sudha ma'am, Dr. KD Nair, Dr. Kuldeep, all of you have blessed us, and we are very, very, very sure that it'll go to next generation. Thank you very much, Shweta.
Thank you. Thank you, sir. Thank you, sir, always for guiding and pushing us. So I think this particular webinar has, I'm very happy that you have taken out time. 4 o'clock sharp, what you said, you have joined. So thank you very much, sir.
Thank you.
So I will I think, invite before Dr. Shweta is going to join us soon. I think she is just busy with a phone call. So before that, let me just start with the chairperson's introduction. We have Dr. KD Nair, sir. Can I have CV of KD Nair, sir? We all know him. He has been our immediate past president, and he has had various awards at international levels, so 27 international presentations in ASRM and 25 international presentation in ESHRI. And he has been always again guiding and pushing, and I've learned a lot from sir. Thank you, sir, for joining us. We also have Dr. Sudha ma'am. Please show the CV of Dr. Sudha ma'am. Sudha ma'am is a director of Matritva, and she had been teaching in past head of the department of Maulana Azad Medical College. She had been our past president of Indian Fertility Society and also the past vice president of FOXY 2019. Thank you, ma'am, for joining us.
Thank you.
And we have Dr. Roya ma'am. Dr. Dr. Roya ma'am. She has been our convener of mentor now of SIG Endometriosis. She is a professor and head of the Department of Shadan Institute of Medical Sciences at Hyderabad. I think she is actually not very well. She has backache, but she will be joining soon. Then we have Dr. Leela Krishna. Can I have her CV, please? So, hello, Dr. Lakshmi. So she's a senior consultant fertility specialist at Lakshmi Fertility Center, Hyderabad. And she has been she has been the secretary of Telangana chapter of Indian Fertility Society. We also have Dr. Arun. Can I have his CV, please? Dr. Arun had been the past head of the Department of GMC Udhampur. He has been the visiting professor of ICOG, and he's also the member in the Quality Assurance Committee of Union Territory and JNK. So thank you, sir. Dr. Arun is also here with us. So I'm going to now hand over to our chairpersons. So over to Sudha ma'am, KD sir, and Dr. Arun and Dr. Leela Lakshmi. Sudha ma'am, would you want to introduce the next speaker and the talk, please?
Yes. Can I have the CV, please?
Rahul, if you can show the CV of Dr. Kuldeep, sir. No, the last slide only. Last PPT only. Yeah. And also, please unmute all the chairpersons. Yes. Yeah. Next slide.
So, not other than Dr. Kuldeep Jain, who is a very well-known in Indian Fertility Society, the past president, the founder member, founder secretary, and he is a very, very active person in Indian Fertility Society, and he is going to deliver the surgical methods, tip and tricks. It is very much important in endometriosis, as the endometriosis is very enigmatic disorder, and we do not know which patient will be all right with the medical treatment or requires the surgical. So let's hear from Dr. Kuldeep Jain that what can be the best method for the endometriosis when the surgery comes. Dr. Kuldeep.
Thank you, Dr. Sudha, for your kind words. Good evening, dear friends. It is really indeed a pleasure to be joining this joint webinar on endometriosis. And I am really happy to see the all activity of SIGs, especially SIG endoscopy and endometriosis. This is a very good, nice idea to combine the same interest SIGs to get a better outcome of these CMEs. So congratulations, Dr. Sweta, Dr. Parul, Dr. Mansi. On behalf of SIG endoscopy, because I am the mentor, so I bring greetings from SIG, and the SIG endoscopy is basically doing a lot of innovative programs, especially the Journal Club, the Young Turks, and uh, other members of the chapters. So I invite all of the chapters as well as SIGs to take joint participation with SIG endoscopy. That will be really great. My talk today is on tips and tricks of surgical management of endometriosis. I bring greetings from my center. This is my birthplace for last 2 years now. So I invite all of you to visit the center at your own convenience. Endometriosis, we know that it is a disease of dilemmas and controversies. And this is one very good quote from Sir William Osler. I always show it to all my friends. If you don't know endometriosis, you don't know gynecology. Today, in next 20 minutes, I am going to discuss role of surgery in endometriosis management. What are the options available when you go for endometriosis management? Problem of surgery and precautions, because we know that surgery is one of the option available for endometriosis, but there are a lot of problems and you need to take a lot of precautions, especially in those patients who are infertile. I will like to share my experience and some of the tips to get best outcome when you are enucleating endometriosis or endometrioma. We'll review some of the evidences about the recurrence, because that is another problem with endometriosis. Whatever you do, whether you are doing a medical management or surgical management, it recurs. So what is the current evidence? How much is the recurrence rate after surgery, and how you can reduce it? And finally, some of the concluding remarks. We know that endometriosis is a disease of controversies and complexity. It is a chronic disease and having multiple factors uh, uh, in it. It is a progressive disease. We have to remember that whatever treatment we are providing, whether it is medical management or surgical management, we need to remember that it is a progressive and recurrent disease. It is not malignant, but behaves like one, and difficult to diagnose, especially when there is no endometrioma, and difficult to treat. We know that laparoscopy is best tool for diagnosis, treatment, and follow-up. So laparoscopy remains a very important part in the management and diagnosis of endometriosis. When the patient doesn't require, has completed the family, then of course a definitive surgery is the ideal thing, like hysterectomy and bilateral oophorectomy you can do, and that is really effective in relief of pain and provides definitive treatment. But problem is when the patient is infertile, fertility is the issue, you cannot go for a definitive treatment. So for infertile patients, what are the options available? Let us explore that. One is the conservative treatment like transvaginal ultrasonography, guided aspiration, and laparoscopic aspiration. They are not the option anymore. We have learned over the period that these are not the options and should not be offered to our patients. So please remember, because there are a lot of young delegates also, and this is one message which I like to give, that laparoscopic aspiration only is not the option available, and one should not go for it because of the very fast recurrence and infections. So this option should not be offered to the patient. The next option is you can excise the lesions if they are at the focal point. Very easy to excise, but again the use is limited when there is miliary involvement of the peritoneum. Then you cannot excise whole of the peritoneum, and then you need to fenestrate or fulgurate. And then there is the better option of cystectomy available. You can combine both cystectomy as well as the fulguration in the management to get better outcome. Then nodule resection, excision, adhesiolysis are other options in endometriosis. Now, how surgery can help in fertility enhancement? We know that there is a tubo-peritoneal anatomy is disturbed. So by surgery, you can restore the anatomy. That is one. Ovulation is not interfered, so patient can start trying the next cycle. You can change the internal milieu in favor of pregnancy, so the implantation rate gets better. There is instant destruction of ectopic endometrium, so the debulking is there and the recurrence rate can be prolonged. And we get a larger disease-free interval. This is the X-ray guidelines 2007 and then 2023. They say the best option is when you are having a grade 1, grade 2 disease, you can go for endoscopic surgery, correct the tubo-ovarian relationship, and then patient can go for IUI for 3 to 4 cycles. Post-laparoscopy, there are many studies that before laparoscopy and after laparoscopy, the fecundity rates are significantly higher. So it is always better to treat the disease and then go for IUI. However, in grade 3 and grade 4 disease, when you are having a large endometrioma or a recurrent disease or bilateral endometrioma or DIE, then even if you do the uh, uh, relationship maintenance, the treatment of choice remains IVF or ICSI in these patients to give a better outcome. What are the factors which influence your decision whether you should go for a laparoscopic surgery or you have to go for ART directly? These are some of the points which you need to remember. One is the age of the patient, which is very, very important. Same stage of the disease, if the age is elderly patient, then it is better to go for what you call ART. If a young patient, you may opt for a surgery and then decide whether the IUI or IVF is to be done. So age of the patient is very, very important factor, and it should be taken into the decision making. If you are not certain that you are dealing with the endometrioma only, certainly endoscopy becomes a better tool. What are the patient symptoms? It is only infertility or patient is having intractable pain also. That is also taken into account. Then, of course, the ovarian reserve is one important thing which needs to be taken into account when you are deciding about the surgery or ART, apart from other factors like size of endometrioma, duration of infertility, previous treatment, and so many other points. Like if the patient is having a severe male factor, then you move on to the ART faster. When you decide as an infertility consultant, these are the important concerns like ovarian reserve and AMH. What is the baseline? Recurrence, we are always worried, and minimizing complications. So when you are putting a scope and treating endometriosis, you must be concerned about all these three things. A principle of surgery in endometriosis is like good surgical technique. You must know, you should be well versed about the anatomy. Endometriosis is one disease which always gives surprise when you go inside. So you have to know, you have to prepare yourself mentally. Meticulous hemostasis has to be maintained. You have to operate in right planes, gentle tissue handling, especially when you are working near tubes, because it is not definitive surgery, it is a conservative surgery, and you have to preserve the ovarian tissue, you have to preserve the tube, and so you have to be very gentle with the tissue, and that's why the minimal use of cautery is recommended. These are some of the videos which I will like to highlight here. uh, I am not showing grade 1, so I am directly going on to the grade 2. Grade 2 is when there is the multiple implants over the surface of the uterus, peritoneum, ovary. There is no endometrioma as such. But these patients, they do have pain, they do have infertility, and how to treat them. If you go inside, you have to thoroughly scan the pelvis, identify the lesion. You will get all types of lesion, like it may be opaque lesion, it may be white lesion, it may be red lesion, it may be brown lesion, it may be black lesions. So identify all. Sometimes there is very minimal endometriosis, and if you are not very careful in picking up them, then you come out that everything is okay. So you have not treated it, and once you identify, best way is if there are two or three uh, endometriotic spots, you can just excise them. But in patients like this, here the whole pouch of Douglas is having miliary endometriosis all over. So you can fulgurate them. Now, fulguration can be easily done by bipolar. A good bipolar works here very nicely. So you are doing surface cautery here. So what is important when you are cauterizing near the tube, near the ureter, near the bowel, you have to be very careful. And most of the time, the tubes are patent in such patients. So once you do the fulguration of all the lesions, you have to just give a thorough lavage. So the internal milieu is changed at the end of the surgery, and you come out after testing the tube. And then from next month, you can go for what you call IUI. Now, this is the video of another advanced disease where there is a endometrioma, a small endometrioma is there. And most of the time, endometriosis starts from the ovarian fossa. Okay, so there are always adhesions in the ovarian fossa. So best way is to just do the lifting of the uh, tube, give the traction, ovary, and give the traction. Most of the time it comes off the bed. Uh, so blunt dissection combined with, I am using a lot of aqua dissection here to clean the area as well as to find out the plane. So traction and aqua dissection is all required to separate the ovary from your fossa. And when you are doing the lifting of the tube, lifting of the ovary, which is containing endometrioma, usually it gets ruptured. So don't worry about that. You just drain it and do the cystectomy. And again, this is whole posterior surface of the uterus is having a lot of endometriosis. So again, it is a severe grade of endometriosis. You can see one blab here. So this is a jelly which is named named by Khurd, Sanjeev Khurd. So we call it as Khurd jelly. That is one of the important sign of endometriosis. When you are not seeing any endometriosis spot, only the jelly like it is a endometriosis. You can diagnose it. So it is one of the important sign. And once you have done the cystectomy, you can just do lavage and fulguration. What are the problems when you are doing a lot of fulguration? There are chances of ovarian failure. So you have to remember that you don't do extra fulguration. You have to fulgurate only the endometriosis, not the normal tissue. You have to be very careful. Otherwise, the risk of ablation, risk of POF in ablation is always there. Same is with cystectomy. Recurrence, usually we avoid surgery. This is grade 4 endometriosis. You see bilateral large endometriomas, whole POD is obliterated. So this is a very advanced disease. And here you can see again the process remains same. You have to just lift the endometrioma. You can see bowel is also adherent there. So there I will do the sharp dissection. Near bowel, always do the sharp dissection. No blunt dissection is to be done near the tube as well as near the bowel. So here again, I am doing the sharp dissection near the fimbria. So you have to separate the fimbria. A large endometrioma was there, and you can see it is very active disease. So there may be some bleeding. Nowadays, I have been using, this is the stripping technique. So you have to strip, find out the plane. I use a lot of hydrodissection, which causes less damage. I use vasopressin now in active disease as well as in large endometrioma. That also reduces the hemorrhage. And so you use less current. When you are using less current, the ovarian damage is less. And here again on the other side, we have uh, separated the cyst from the ovarian fossa, and this is the cystectomy, which is, you can see the cyst is coming out so beautifully when you are finding a plane. So it is always important, because it is a pseudocyst. You may not always find a good plane, but try to find a plane where you can demarcate that this is cyst wall and this is uh, endometriosis. This is normal tissue. And then give the traction in right direction. Again, this is very important. If you are not giving traction in right direction, like here, it has to be at 90 degree. 90 degree traction is required. And it comes out very easily. Again, doing cystectomy is not all. You have to do the fulguration at the end of the surgery. You can see the posterior wall is full of endometriosis. Pouch of Douglas is full of endometriosis. When you are doing the fulguration near the ureter, you have to trace the ureter completely at the uh, end of the surgery, so to avoid any complication. So the stripping technique, I told you, it takes care of minimizing the damage and inadvertent removal of normal ovarian tissue. That is well known. Now, this is again a very severe case of endometriosis, having bilateral endometrioma. Drainage, usually we do when you are lifting, the drainage occurs. But if it is not ruptured, then just go by the by your trocar and aspirate whole of the fluid from inside the endometrioma, and then uh, start doing the cystectomy. Now there is always a debate that whether you should do the fulguration or cystectomy. Now, as far as the fertility is concerned, when you are doing the fulguration or cystectomy, the fecundity rate are almost same. But the recurrence rate, here you can see the bowel is adherent here. It is a severe endometriosis. So you have to be very careful, and usually these type of adhesion, they should be tackled by scissor. Now this is, we are lifting from the bed. So what I was telling about the fulguration and cystectomy, but the recurrence rate are very high when you are doing only fulguration. So always try to do the cystectomy, but at the same time, when you are having AMH very, very low, then you can combine cystectomy as well as fulguration to minimize the damage. So this is the plane. Once you find the plane, the cystectomy becomes very easy. The traction and counter traction leads to the cystectomy. Now this is again a very, very severe form of endometriosis. Here you cannot lift it is a frozen pelvis basically, and you see all sorts of uh, endometriotic spots. The jelly is there, then the thick adhesions are there. The anatomy is completely disturbed. So these are the patients which are really challenging. Tubes somehow they are patent, but even if the tubes are patent, after surgery these patients they should go for ART rather than wasting time in conservative management or IUI, because the fecundity with IUI in such patients will be very, very low. So that you should remember. Uh, Again, you see the separation, there are thick adhesions here in the posterior pouch and the posterior surface of the uterus. We have separated uterus from here. The cyst was here and we have separated. So slowly and slowly you try to find the plane. Usually from the normal area, you go into the disease area. So the plane is easy to find. Like here, lateral side, if you are going, then uh, the plane will be here. From here, because on that side, it was very, very thick. So I left that plane. And from here, you can just lift the ovary from its bed. Okay, so that is how you have to manage. So presence of mind is very, very important, and planning on the table is very, very important. Now, such type of patients, again, they require a lot of expertise. The bowel is adherent, you don't see anything. And sometimes it takes a lot of time, and the complication rate are very, very high. This is adenomyosis combined with endometriosis. So these are some of the patients which are really challenging. You can see the adenomyomectomy going on. A large adenomyoma is removed from this patient after doing the GI dissection. So how to prevent the GI complication prior to surgery? One should do a PV and PR, very, very important. If there is a fixity of the rectum or fixity of the colon, that needs to be kept in mind. You must do a transvaginal and transrectal ultrasound to map the disease. MRI sometime is required and may be very, very helpful in severe cases. Bowel preparation is very important in endoscopic surgery, so you must do a very good bowel preparation. These are some of the things which you cannot go without them. In high-risk cases, in severe endometriosis involving colon, rectovaginal space, patient with history of previous GI operation, in nasogastric tube or mask ventilation should be given, and informed consent is very, very important in all severe cases. To opt for lateral dissection, which I have already highlighted. Now, bladder endometriosis, again, superficial peritoneal implants on bladder, careful dissection can be done. Infiltrative lesion, you have to do partial cystectomy, and, then close the bladder. Adhesions between anterior uterine wall and fold, they are divided by, again, performing the partial cystectomy. And finally, you must do a cystoscopy at the end of the procedure. This is some of the literature, very old, but again, these are 4 cities, and there is good evidence that excision surgery provides more favorable outcome for recurrence and spontaneous conception when combined by when compared with coagulation. Now, some tips to reduce recurrence. You have to do complete surgery. If you have not done a complete surgery, recurrence rate will be very high. So always when the endometriosis is being operated, you must do the complete debulking and complete surgery. The recurrence rate will be very, very less. Intestinal adhesiolysis and extensive ureterolysis may be required to reach to the endometrium, because what we do, we don't go very deep and we leave a lot of endometriosis. So these patients, they do require a thorough surgery, even if it requires a help of second person. Detection and differentiation of endometriotic lesion from healthy tissue. That is again very important. You have to know that which is the healthy tissue, which is the endometriotic tissue, and excise the endometriotic tissue. This is some of the literature, surgery and pain. We know that the pain is reduced by 50% in most of the cases. Maybe if you have done a very good job, and post-operative, if you are given GnRH agonist for 3 to 6 months, the pain is significantly reduced. This is very recent paper on recurrence, and they have concluded the recurrence rate after conservative surgery is around 23.2% at the end of 2 years. But overall recurrence rate was in this series 56 points. So you see, even after doing a very good surgery, you cannot guarantee that recurrence will not be there. And many times recurrence is as early as within 6 months. Risk factor are severity. If the disease is more severe, the recurrence rate will be high. If the disease is mild, moderate, the recurrence rate are very few. How much adhesiolysis you have done, how much you have removed, that is again very important. And post-operative hormonal treatment. That is, if you are given a post-operative hormonal treatment, the recurrence rate can be reduced. So these are some of the factors which are important in these patients. You can see the recurrence rate at the end of 156 months, the recurrence rate was as high as 75%. Again, when the patient receives hormonal treatment, this is hormonal and this is the recurrence rate. So you can see the recurrence is higher when there is no adjuvant treatment is given. This is the line. You should not be in such a position when you are doing endometriosis surgery in the theater. To avoid this situation, you have to discuss amongst your colleague, amongst your team, what you are planning, and you should always be prepared for a surprise during your surgery. Surgical expertise and anatomy is very important. If you know your anatomy well, you are a good surgeon. That goes without saying. So know your anatomy well when you are doing endometriosis surgery. We know that there is a effect of repeated surgery on AMH. So try to avoid repeated surgery. The guidelines to minimize risk and complication. I am having 2 more slides and I tried to cover exhaustively all aspects. You have to check your instrument insulation because that might cause problem. Always use lowest possible power. Low voltage current should be used. Interrupted and not continuous activation. That is very important. So, dear friends, concluding my talk, most of the complication during laparoscopic surgery can be avoided by gaining the knowledge, improving your surgical skills, and increasing expertise by operating more in number and severity. Severe forms of endometriosis and DIE demands complex surgery, and radical approach is mandatory to improve the outcome and quality of life. Scrutinizing preoperative work is very, very important. It is mandatory. Sometimes complications cannot be avoided, but benefits versus risk must be evaluated, weighed, and then told to the patient prior to surgery. Patient counseling, very, very important. Preoperative investigation, very, very important. Multidisciplinary approach, again in endometriosis surgery. When you are dealing with bladder and rectal endometriosis, you should have a help with you. Instrumentation, good instrumentation, surgical team, sound knowledge. Organ sparing surgery, which I have not covered in this lecture, very, very important. Documentation of procedure, very important. I take this opportunity to invite all of you. Now we are 1 month away from this great conference coming to us, Fusion 2024. And I hope all of you have already blocked your date, did the registration. If not done, then please do it today. This is a opportunity of going to X-ray in Jaipur. So block your date and join us here. Thank you very much for your kind attention. Thank you.
Thank you. Thank you, Dr. Kuldeep, for the excellent talk from diagnosis to management and the complication. And you have given a beautifully tips how to do it. Definitely, it requires a skill. If the skill is not there, we can make more complication than treating the patient. Number one thing, what I want to say that we should always, other than our team, we should always talk to the patient. What exactly you are going to do and what all can happen. And they should know very in a transparent manner that what exactly is going to be done. Number one. Number two, if the patient is wants the pregnancy in future, the question is, if she is with endometrioma, the grade 3 or 4, it's better to do the retrieval first, oocyte retrieval, or will you like to do the surgery first? Because what I have seen, my experience, that if you do the surgery of a big endometrioma, you are going to have more complication, more problem, and the whole of the ovary is going to be engulfed by the surgery. So these are the two things, and we have few questions in the chat box. Will you, I hope it will take a few minutes.
I will be able to take, one thing which the decision making, I included one slide, and there I made it very clear that it depends on multiple factors, not only the one thing. If the patient is young, not very much in the duration, like and there is no compromise reserve, we prefer going for surgery. But if there is any of the combined problem, like if there is a decreased ovarian reserve, the AFC is very low, AMH is very low, patient has already taken multiple treatment, then certainly once you decide ART, then you don't touch the endometrioma. Then
very rightly said, because the medical treatment comes first.
Once you have decided for IVF, then we don't touch. Even in the large size endometrioma, you can retrieve the good amount of egg harvest, which can give you a pregnancy. Now the question is whether after retrieval you do the surgery, or you give post-op this GnRH analog. That will depend on the symptoms and other thing. If the patient is having symptomatic pain, etc., is there, you can go go for surgery. Otherwise, we don't go for surgery in small
Very
endometrium.
rightly said. So there is
5
one
centimeters.
question: why not to do peritoneectomy instead of too much of fulguration? I think the audience was not very happy with
You can
fulguration.
do, yeah, you can do peritoneectomy, but again, how much peritoneum you will remove, that will depend on the case I saw showed when you are working in the POD. In POD, stripping of endometrium is not free of complication. So avoid it. You do fulguration and come out. If you do the peritonectomy in the pouch of Douglas, you are going to create more complication, more bleeding, and it may not help. When you are doing the parietal peritoneum, yes, you can do the peritonectomy, but
Yes,
again,
very rightly said.
amount of disease will decide whether you have to do the fulguration or do the peritonectomy.
So Johnson Bagra is also asking about the pre and post-op hormonal treatment. The pre-treatment, so I don't think anybody gives. Patient has tried so much, but post-op hormonal, after doing your complete surgery, even though the chances of recurrence is always there, will you like to give hormonal treatment afterwards?
See, usually in grade 1, grade 2, you don't give any hormonal treatment. You just correct the tubo-ovarian anatomy and do fulguration and start treatment in the next cycle. When you are not very sure that you have done a thorough debulking, we always give when we feel that yes, there is some more endometriosis is there, you can give post-operative treatment, 3
Because
months
already you have shown
general.
54% of the recurrence in a good center. So I think the hormonal treatment has to begin. So thank you
Hormonal
very
treatment,
much.
that is what I am saying. But and especially when you are planning for ART, these patients, they either you retrieve first and then give the post-operative treatment, do the surgery and treatment. So depending on you have to individualize what you are planning in the next. If you have done a very good job, there is no need to give post-operative treatment. But yes, in grade 3, grade 4, usually
Definitely,
we give,
yes.
usually to reduce the recurrence, 3 months suppression is working very well.
Okay, thank you. Thank you, Dr. Kuldeep. Very well done. Thank you so much.
Thank you, Dr. Sudha.
I will hand over to Shweta. Yes.
Yeah, so we have Dr. Arun. Dr. Arun, you want to add anything? Dr. Lakshmi also.
Yeah, thank you, Dr. Kuldeep, for such an excellent presentation.
Thank you.
Thank you, sir. It was very enriching and enlightening. Thank you so much, sir.
Thank you, my pleasure.
So thank you, sir. Thank you for such a nice video and all the pictures. Thank you very much. So now we move on to the next. We have two panel discussion. The next panel discussion is moderated by Dr. Soumya Prasad and Dr. Parul Garg. So can we have their CV, please? Yeah, so we have usually with endometriosis two types of patient. One is which is mainly has come to the clinic for pain, and the other one is when we have an infertility problem. So first we are going to have a case discussion on case-based discussion on the pain, And we have Dr. Soumya Prasad. Next slide, please. So she is a senior consultant at the back slide, please. She has at the Matritva. Rahul, can you just put back the last slide? No, the previous one.
I've changed it.
Yeah, so she is no, it's okay now. Senior consultant at Matritva Advanced IVF and Maternity Center, New Delhi. And she is also our co-convener of SIG Committee Endometriosis. She is an executive member of Indian Fertility Society and also assistant web editor 2022 to 24 of the Indian Fertility Society and co-editor of AOGD 2021 to 22. And then another moderator we have. Next slide, please. She is Dr. Parul Garg. She is the present working head of the Department of Reproductive Medicine at Artemis Hospital, Gurgaon. She is the executive member of Indian Fertility Society from 2022 to 2026. She is a co-convener of SIG Reproductive Techniques, IFS, and also co-convener SIG PCOS. So over to you both, Dr. Soumya Prasad and Dr. Parul Garg, for the panel discussion.
Thank you, ma'am. So we'll start our very interesting panel on pain and endometriosis. So I would like to welcome our panelists for that. Dr. Pikki Saxena, ma'am. She is Director Professor of Gynae LHMC. Ma'am has many medals, gold medals to her name. Editor of 6 books, published more than 230 articles and more than 250 invited talks. Dr. Rupali, ma'am is senior consultant in Indraprasth Apollo Hospital, Sarita Vihar. She is also the editor of Indian Fertility Society, joint editor IFS 2022-24, web editor, and our executive member of IFS. Dr. Garima Sharma, she is the center in charge and IVF consultant at Gunjan IVF World Janakpuri and received budding IVF specialist of the year North from ET Health World National Fertility Awards 2023. Dr. Neeti Tiwari, ma'am is senior consultant at Sri Gangaram Hospital and has presented many papers at national conferences, authored and co-authored chapters, and has many publications to her name. Madam is executive member IFS 2022-24, co-convener of SIG POR 2022-24. Dr. Manjusha, ma'am is senior consultant at Max Healthcare, Lucknow. She is the secretary, chapter secretary of IFS UP East chapter and executive member of LOGS, APLGA, AGOI, and has reviewed more than 400 maternal deaths at important publications include review of more than 400 maternal deaths at government facility, Delhi. Dr. Shahida, she is consultant and center head Birla Fertility and IVF, Preet Vihar. She has done her FRM from Gangaram Hospital and co-editor of Manual of ART and Lab Sciences. Sonika Sharma is a senior resident. She's done her fellowship from Inspire Laparoscopy and IVF Center. Dr. Kashika Katuria, Madam is Senior Consultant IVF at Primax Healthcare, Consultant Obs-Gynae Fertility and IVF Specialist Laparoscopic Surgeon. She's also the Visiting Consultant at Fortis Shalimar Bagh. So with that, we are going to start the panel. It is on endometriosis and pain. So this is a brief introduction that endometriosis is the presence of functional endometriotic tissue in the peritoneal cavity, usually observed on the outer uterine walls and the ovaries, but sometimes occurring as far as on the diaphragm tissue. It is a complex reproductive disorder affecting about 6 to 10% of the reproductive age women worldwide. But the estimated prevalence of the endometriosis might be underrepresented because of the practice of disregarding young women's menstrual pain among the gynecologists. So this is the classification given by ASRM, which is based on the severity, the size, depth, location, and amount of lesions, present endometrial lesions. And then we have another classification by EFI, Endometriotic Fertility Index, which includes the assessment of historical factors at the time of study. So that is why the history taking is important of adnexal function at the conclusion of the surgery and the extension of the endometriosis. So with this very brief intro, we'll start our case study. Mrs. X, a 32-year-old woman, she came to the clinic with complaints of moderate dysmenorrhea, chronic pelvic pain, and painful intercourse. Her menstrual cycles were regular, but it was accompanied with significant pain, which starts a few days prior to the commencement of menses. So my first question is, can specific signs and symptoms help in predicting endometriosis? Picky ma'am, can you tell us if any signs and symptoms which we look for when we are diagnosing endometriosis? Dr. Picky ma'am, is she?
Sorry, I was not able to unmute. Thank you, Soumya. So I think it is very, very important, as you just told, and in the first lecture we found that the history taking is extremely important. Severe dysmenorrhea, which is secondary dysmenorrhea. The primary dysmenorrhea is the one which starts before periods and finishes by day 2-3. But here there is congestive or secondary dysmenorrhea, which will continue throughout periods. And the girl, if she's a young girl, she has to take chutti from the school, and the pain is there probably constantly. It may be a chronic pelvic pain. If she is married, then she will have dyspareunia, dysmenorrhea, dyschezia, dysuria. All those types of pains generally are there. Bleeding is mostly regular, but it could be acyclic also, and it could be very heavy. So this is very important. And if the mother has had, mother or sisters or masi, if they have a family history of having painful periods, and it is also said that if the girl has asthma or migraine and thin or lean patient, she may have problems like constipation and diarrhea also during that time. So all these things are very important. Also, when we are examining, should I talk about examining or another
Yes,
person?
ma'am, you can, because we're not discussing examining, but I think it should be done here only.
Yeah, I think it's very important. If it is not an adolescent girl, we have to examine the per abdomen if there is any mass felt. If after that we have to do a tender mass may be present, then we do a PS and PV and PVR. And if the uterus is fixed, if it is tender and the fornices are full, or we can feel a solid, a cystic mass, those all things will point towards endometriosis. Or if the uterus is globular and it is tender, then it could be adenomyosis associated with it. We may see a bluish hue in the PS examination. And PVR is extremely important. As it was being mentioned, the in the uterosacral ligaments or in the POD, we can feel nodules. So those nodular thickenings, all these things will point. If it's a adolescent girl, then also we should tell the child that we are going to do a PR. And many of the adolescents are sexually active. So we can take a history, and after taking consent, we can do a PR or PVR, whatever is there.
Right. Very rightly and very nicely explained by ma'am that the history taking is very important when we are talking to a patient, because the diagnostic modalities are sometimes not very, cannot be done for the patients individually. So taking a sexual history and then going after history taking, doing a physical examination is a very important marker. So when we talk about pain, we should take a very brief and nice history. How does the pain start? Does it start before menstruation? Is it there with the intercourse? Does it happen on deep thrusting? Is there dyspareunia? Does she have suprapubic pain, lower back pain, or she has been having chronic pelvic pain for last 6 months? Is there any pain, rectal pain? And does she have any premenstrual spotting, irregular bleeding, menorrhagia, any urinary symptoms, or any digestive symptoms are there, diarrhea or constipation, or even IBS patients have with endometriosis, a lot of patients present with IBS also. So all these history is important, but because these history points are associated with other differential diagnosis also. So just on the basis of history, we cannot diagnose endometriosis, and that is when a physical examination is also required. So if the patient is not sexually active, a parectal examination should be done to feel any nodules. So there are many guidelines which have suggested whether history taking can be diagnosed endometriosis on just the basis of history taken. So only ASRM said that laparoscopy before empiric treatment is the prefer. A lot of said that laparoscopy should be done before empiric treatment, and most of the ACOG also said that surgery is the only way to definitive diagnosis with the histological verification. SOGC also said investigation of suspected endometriosis should include the physical patient's history, physical examination, and imaging. So all these things have to be taken in account, not only just the laparoscopy that we will tell the patient that we can only diagnose after doing your laparoscopy and doing a histological verification of it. And then when the patient complains of dysmenorrhea, it is divided into two. There are two types of dysmenorrhea, primary and secondary. Like ma'am said, the primary one usually starts at the onset and it stays for 3 days during the follicular phase only. But if the patient has endometriosis, the pain is progressive. It can be cyclical or acyclical and will extend beyond the 3 days of the follicular phase. Plus the primary dysmenorrhea, it will respond to NSAIDs, though there is not much role when the patient is having endometriosis dysmenorrhea. So now the question comes, why is this pain happening? What is the cause of the pain? Dr. Rupali ma'am, if you could answer this question. What causes the pain, or in patients with endometriosis, the different kind of pain, if she's having lower back pain or if she's having a loin pain or suprapubic pain, why is it happening?
So usually it is seen that with endometriosis, the degree of pain might not actually correlate with the size of the lesions. It would.
Ma'am, your voice is very low. Can you increase the volume?
It's maximum. Is it better now? I mean, it's in maximum. Should I switch off my camera maybe? Hello. Yeah. Is it better now?
Better. Yes, ma'am.
Yeah. So usually it is observed that the pain which is there in endometriosis patients, it does not correlate with the, with the size of the lesions or with the presence, with the extent of the disease. Sometimes even with minimally found endometriosis, patients complain of very severe pain, whereas sometimes they might have bigger lesions to have pain. Now, this pain which happens during endometriosis is primarily due to nerve involvement. It also occurs because of release of various factors like the cytokines. I mean, Dr. Manjusha is saying she can't hear anything. I'm on my.
But you are audible, Dr. Rupali. You are audible.
Yeah, Dr.
Yeah,
Manjusha, check with your computer. Maybe it's on low volume.
All right. So, so it's obviously related to the fact that there are nerves, there are pelvic nerves which are getting stimulated, which are leading to such a pain. Apart from that, there is release of prostaglandins, cytokines, the pro-inflammatory factors. Now, these inflammatory factors are the ones which really cause a lot of pain, which lingers on for much later on as well. Sometimes patients would have a coexisting PID as well, where they have these, where they have this kind of a pain. So a thorough clinical examination will help us to rule out, as well as investigations will help us to know what kind of endometriosis it is and what is the extent of nervous involvement. That is why traditionally, Luna used to be used previously, stating that it's probably because of the nervous
We will come to that, ma'am, in the next case. Yeah. Okay. Dr. Neeti, ma'am, do you want to add on to anything to what is the cause of the pain in patients with endometriosis?
What we know about this is only the nervous system involvement, these peripheral nerve fibers which are involved in the adhesions. They could be involved, because of which there could be pain. So that is very specific to endometriosis and adenomyosis. So that's why the pain which a patient feels in a adenomyotic lesion or an endometriotic lesion is very different from, what a patient would get, for example, with a fibroid. So the menorrhagia or the dysmenorrhea which a patient feels with endometriosis is very specific because of the involvement of these nerves.
Right. So that has been discussed, that there's an interplay between the immune system, the lesions, and the peripheral nerves, and all this. There's a release of cytokines, the growth factors, which is secreted by the immune system, and that sensitizes the peripheral nerves to the specific surface receptors, causing the pain in the patients. So when a patient complains of a persistent cyclical pelvic pain, it could probably be due to a chronic inflammation, which leads to fibrosis, formation of adhesion. If she has dysmenorrhea, severe dysmenorrhea, then it could be due to the hormonal fluctuation during the menstrual cycle, causing endometrial to thicken, break down, and bleed. And this process triggers the inflammatory cytokines and prostaglandins. If she has significant ovulation pain, the mid-cycle pain, then the rupture of the ovarian follicle may also exacerbate the presence of the endometrial tissue. If patient has so the kind of pain patient is presenting with, it will depict what kind of inner adhesions or formation of any chronic inflammation, what is happening inside. So
Yeah,
if
but
she
it
has
is
lower back pain,
it is the neurogenic thing, which is very specific to endometriosis and adenomyosis.
yes ma'am, yes.
Neurogenic.
And
It-
also, I think the adhesions can also play a part.
Yeah, so
When
the nerves are getting entrapped there, no? So
and all these
as well as the
inflammatory
congestion
markers
which
as
happens for the tissues just prior to periods. So usually it's a triple onset: prior to periods, during periods, and after periods, which lingers on. Yeah.
yes.
Yeah.
So then the question comes, how do we manage this patient? Dr. Manjusha ma'am. Can ma'am hear me? Dr. Manjusha ma'am.
Actually, I was not able to hear things for a while
Right.
and I was out of it. So if somebody could repeat the question, I will be happy to take it.
So the case is ma'am, Mrs. X, 32 years old. She came to the clinic with complaints of moderate dysmenorrhea, chronic pelvic pain, and painful intercourse. She has regular menstrual cycles, but accompanied with significant pain, which starts a few days prior to the commencement of the menses. So the question is, how do we manage such a patient?
First thing we need to understand is what are her fertility needs as of now. So if fertility is not a concern, and the ultrasound is not showing very big endometriomas or anything, I think the first line of management should be medical management. We have several options with us, and we choose them depending upon the severity of the symptoms. I mean, we could choose from Dynogest or maybe the combination pills, tricycling regime, or maybe gonadotropin, GnRH. So this we will depend upon her. We will have to individualize. We cannot really say that one size fits all. So if you could.
Dr. Garima, do you want to add to this? What will be the first line of drugs which you would like to give her?
So when we are talking about the first line of drugs, so anything which helps in suppressing the functional endometrium would be helpful. So for the pain management, NSAIDs are not very much recommended because they are not able to manage the pain. So oral contraceptive pills, the combined oral contraceptive pills are basically suggested by ASHRAE as the strong recommendation to give it along with the progesterones, because it suppresses the functional endometrium and it causes the desudalization, and so it will help in reducing the pain in patients with endometriosis. So for first line of management, combine oral contraceptive pills, either it is given cyclical or continuous. It's basically advisable continuous, or progesterones like norethistron acetate, intrauterine contraceptive IU, or Dynogest, or medroxyprogesterone acetate. These are basically advised as the first line of management in cases of endometriosis for pain management.
Yes. Dr. Picky ma'am, do you want to add something to this?
Soumya, I feel that always in my practice, if it is not a very severe pain, I always go with NSAIDs. And if the patient doesn't respond, then I go to progestogens.
We all go with NSAIDs as the first line, but in none of the
But
studies which
generally,
has
they
been
do
under
not
guidelines, they
respond.
don't recommend
They
because
don't
they say yes.
recommend.
Yes,
But
but the first
second line is always I start with medroxyprogesterone acetate or norethistron or
Dynogest, you don't give
Dynogest.
Dynogest, ma'am?
If the patient is, in our setup in a government sector, we don't have very well
Okay,
off
yes.
patients.
Right.
If the lady can afford, Dynogest would be my first choice because it is anti-proliferative, anti-angiogenic, and one more anti-proliferative, anti-angiogenic, and it reduces the size of this. And of course, it has all the benefits of the other progestogens, inhibiting ovulation, the decidualization of endometrium, which has already been mentioned, and it is a fourth generation progestogens. So the side effects of dyslipidemia, dysglycemia, all those things are not there. And if simultaneously she is having PCOS, then it is also an anti-androgen. So it has number of benefits to its credit, and it is the only drug which also reduces the size to a great extent. So my first choice, if the patient can afford it, would be Dynogest.
Right. So, though in all the studies and literature, it says that NSAIDs is not recommended, but we all give it because that sometimes in mild endometriosis, it always helps and gives us some relief to the patient. It inhibits the prostaglandin production, and it is, since it's very easily available, patient can just buy it, and low cost. It has very less side effects. Then we have neuroleptics also when a patient is complaining of severe pain. These are still under trial, but still can be given if the pain is very unbearable to the patient. Then the combined oral contraceptives, which is very commonly given to reduce the pain due to endometriosis, inhibits the production of gonadal estrogen through a negative feedback, thereby decreasing the production of estrogen, induced release of prostaglandins. Then, as ma'am said, somebody saying. Then the progesterones, which is very commonly now it has started coming up. Dynogest, which was there, but yes, if a patient is in a government setup and not very affording, then Dynogest may not be the first line of drugs to be given to the patient. Then when we talk about COCs, are we giving continuous or cyclical COCs, ma'am?
Soumya, I would like to take this here.
Yes, ma'am.
See, if we were to give just a 21 days on and 7 days off phenomenon, we don't really end up achieving the kind of suppression that we want. And if we were to give a continuous thing, then the patient comes back with threshold bleeding. So our middle path, which is recommended also and which we have been doing practically also, we do a 63 days on, 7 days off regime. And it has very good response on the pain as well as the quality of life parameters. And threshold bleeding is generally not a problem. Some women, of course, come back at about, say, 55 days of usage with threshold bleeding. And then we can tell them that, okay, now that you're having threshold bleeding, give a gap and then restart after a week. So the 63 days on, 7 days off regime really works wonders in these girls.
Dr. Kashika, ma'am, do you want to add something to this, cyclical or continuous? How do you give COCs for a patient with endometriosis?
Yeah, so for suppression of pain symptoms, especially when there is dysmenorrhea, I generally prefer to give continuous OCPs, and that is what is recommended, similar to what Dr. Manjusha is saying. So basically, 3 cycles would be 63 days. So whether we're giving Dynogest like Endorec or COCs, we generally have a follow up after 3 months. So 3 cycles, we give it continuous, and we see. And that is when you actually achieve a complete suppression, especially when dysmenorrhea is very prominent and you are giving continuous. That is when the patient will actually experience the benefit, which is not, because the endometriotic implants are not going to be bleeding in your 7 days gap. So that is the advantage of giving continuous.
Very rightly said. Dr. Rupali, ma'am, you also give continuous?
Yeah, indeed. I have been giving it longer also for 84 days and then a gap of 7 days for my patients, depending upon the severity of symptoms. And I personally really like this drug because in smaller implants, In patients who are symptomatic with smaller sized cysts, it has shown to reduce the size of the cysts. And I think it has tremendously improved the quality of life in patients with endometriosis who are not concerned about fertility. So I'm personally very fond of this drug, to be honest.
Right.
Yeah.
Very good.
So there have been many, this is a RCT, but where they felt that there was no significant finding a difference between the cyclical use and continuous use of patients of OCPs in
Dr. Soumya, slide is not moving, beta.
Which slide is on, ma'am? This is the
first line
slide
wala slide hai.
NSAID slide.
RCT is not coming up.
Is it moving now, ma'am?
No.
But we can see moving.
Actually, yeah, it's been put in the group. I do not know how.
It's showing the first line, the NSAIDs wala slide.
Though I can see the long-term cyclic and
Long-term slide you
continuous
can
one.
see, Garma? Okay.
Yeah, I can see that.
I think some people are able to see. I do not know.
Okay, doesn't matter. You speak up.
Right. So this is an RCT. It is an old RCT where they said that there was no significant finding difference between patients using cyclical or continuous. But then many other guidelines came and they said that continuous. The recent one, ESHRE 2022, said that the continuous use of OCP and the associated achievement of amenorrhea rather than the standard cyclical use has been suggested as an effective treatment for endometriosis associated dysmenorrhea. So what other medical treatment options do we have other than these COCs and Dinogests, which we talked about? Dr. Sonika Sharma? Sonika? Dr. Sonika?
Yes, ma'am.
What are the other medical options do we have? Second, what are the second line of drugs?
We can use GnRH antagonist.
Agonist.
Oh, agonist. Leuprolide.
Right. Dr. Picky, ma'am?
Yeah, so if she's a married woman, I would like to give her a LNG IUS because it's a one-time thing. It gives compliance is good and it shows good results. There is no effect. It's not absorbed in the blood. So the side effects of the oral drugs are avoided. It does not cause any dyslipidemia, dysglycemia. It is safe in medical practice. Another thing that we can give is medroxyprogesterone acetate also can be tried because it is freely available in the contraceptive national guideline basket. So that is another option which can be tried. And GnRH analogs we give as the last resort because it cannot be given for a very, very long time and it causes the bone mineral density is reduced if we give for a very long time. And when I prescribe Leupride or GnRH analogs, then also it is better to add estrogen or add back therapy if you are giving for a longer time than 3 months. And yeah, we have to also start her on calciums and vitamin D. Because it is said, because this disease is not going to be okay. We have to counsel her very nicely that she has to continue with this problem till she has her menopause or the uterus is removed. We need to spend some time and tell her about the pros and cons of the surgery and all the medical treatment, the side effects. Ki beech mein she can discontinue it, then she has to start it out again. So GnRH should be the last choice because of the problems, hypoestrogenic side effects and BMD problems that it causes.
Dr. Rupali, ma'am, any add to this? What are the second line of drugs which we give? Progesterone, COCs, and all that we come in the first line drug when we give. But what if that doesn't work? Any second line of drugs which you recommend or prescribe?
So I rarely use GnRH analogs in my practice because of the short-term effect. But yes, LNG IUS very frequently if the patient has completed their family, if we operate a patient also, so that it doesn't regrow later on. As a prophylaxis also, we use an LNG IUS very regularly in most of the patients who are paras who are not concerned for fertility. So
Right.
I think that's
So this is just to
Yeah.
complete the list that we have GnRH agonist also. It binds to the receptor in the pituitary and inhibits the pulsatile stimulation. Hence, slowly it acts, it downregulates the HPO axis and causes hypoestrogenism. Nowadays, the nasal spray is also available for agonists. So the spray is done twice daily. 200 microgram twice for 6 months it's given, but then we have to add to give the add back therapy also, like ma'am said, we have to add COC, estrogen, and give vitamin D, calcium has to be added. Then they have GnRH antagonist also. It's been approved only in USA to treat moderate to severe kind of endometriosis. It's not practiced here. Then aromatase inhibitor, which decreases the local
Yes.
estrogen concentration. So letrozole, it does increase the bone loss also. So in with this also we add calcium, vitamin D, and we have to do the add back therapy here. But even that is there. Just to complete the list, aromatase inhibitor. So this is
the nasal spray available
2020.
in India, Soumya?
Right.
Yes, ma'am.
Is the nasal spray available in India?
Yes, it is. It is available, ma'am.
What trade name?
Trade name, I don't remember the trade name, but it is available. Somebody had just come, I think, 2 weeks back only. It's there here. Yeah. So this is the 2022 guidelines. So just to conclude with the treatment options available. But NSAIDs, again, here they have said it is weekly recommended. Hormonal treatments, COCs, like we discussed, progesterones, it is also recommended to reduce endometriosis associated pain. Even they say GnRH agonist also in 2022 ESHRE guidelines recommends to prescribe women with GnRH agonist to reduce the endometriosis associated pain. Although it has very limited evidence with the duration of treatment to be given. Then antagonist, again, it is very weakly, it is not recommended by ESHRE. And aromatase inhibitor has also come up with a good recommendation that we can give this aromatase inhibitors also, letrozoles also can be added. So I'll give now to Dr. Parul, will take over from here.
Can I add something, Soumya?
Yes, ma'am. Neeti, ma'am.
So, when we talk about generic agonists, because we are using it a lot in our practice for pain associated with endometriosis. Earlier, the view was that you can only use it after, you have a laparoscopically confirmed endometriosis. But now the norm is that you can, even if you have not confirmed endometriosis on the laparoscopy, you can start the second line drugs like GnRH agonist depots and Dynogest can be started even when you have not done a laparoscopy, which you were describing earlier, that now it is not necessary to do a laparoscopy before starting these drugs.
Right. So but after post surgery, like sir also said that we should be giving some post treatment. So we do give post surgery also, depot is given.
Yeah, so that is a different indication, but this
Not pain, yes. Not
in
for
your
pain.
case also, yeah. So even if you have not done a laparoscopy, you can start with agonist depots and Dynogest.
So how do you give the depot, ma'am? For how many cycles?
Yeah,
We usually give it for, we usually give it for 3 to 4, doses every 28 days. And then we give a gap. And if you give a gap, after say 4 doses of agonist depots, the effect linger on. So the people, the lady usually doesn't get menses for 1.5, 2 months. So she is symptom free actually for a, 6 months period. So it's a very good drug when it comes to, bringing down the symptoms of endometriosis.
Endometriosis.
And
So
we are
in moderate to
focusing on
severe endometriosis is when you give these
Definitely.
depots.
Definitely.
Rupali ma'am, you were saying something?
Saying that we can give GnRH analogs, but the whole idea is that beyond 6 months or maximum 1 year, the pain subsides away, and then the patient will come back to us, and then again
That is the problem.
Yeah,
That is with all the drugs. That is with all
That
the
is a problem with the medical
But
treatment.
It will
Dynogest
come
can
back,
still-
yes.
Yeah, but Dynogest can still be given on for the next 3, 4 years, 5
We
years.
also give GnRH
Until pain
depot.
subsides. So subsequently with GnRH, the lesion also subsides. With Dynogest, the lesion also subsides, but the duration till which you can give GnRH, that should be very clear.
Has
It's
to
not
be
to be
limited.
more than 6 months. But Dynogest can be given up to 5 years as well.
Yes,
Yeah.
that is. Thank you so much.
But
So now,
one more thing, Soumya,
yes,
even
ma'am.
Dynogest will decrease the bone marrow density. So if you give for a prolonged time, you have to counsel the patient and again add calcium and vitamin.
Calcium, it's fine, and it's been shown to be safe for 5 years. I mean,
It is the best out of all the rest.
Yes.
And GNRH should come last in the choice, but
Yeah,
nothing comes without complications and side effects.
Now, can we start with the case 2?
Yeah, I'll start.
Yeah. Now, this patient is
The slides are not moving.
I think you share again.
This is stop sharing. Yeah.
This is fine.
It's moving
Yeah,
now. Case
yeah. Now
this
we
is-
can.
So this is a 19-year-old girl came to emergency with severe abdominal pain.
Audience won't see, ma'am, Parul.
we can't see anything.
Can't see
Can't see.
anything.
No.
Stop
Soumya.
sharing and share again.
Share again. Please
Stop
share
share and
again.
reshare the
Okay,
slide.
I will.
Dr.
stop.
Parul, you share. I'll stop it.
Okay, okay.
Yeah. Can't see anything.
Now it's fine.
Yes.
Yeah.
Okay.
Yeah, good one.
We missed all these slides, Soumya. I could not see.
Yeah, the good ones. Yeah.
But you spoke well. We understood everything.
Thank you, ma'am. Nobody could see the slides.
I could see the slides.
Okay.
No, I also could see.
They could see. Yeah.
So can I start with case 2?
Please.
Yeah, 19-year-old girl came to emergency with severe abdominal pain. So vitals of pulse rate was 100, BP was 100/80. On per abdomen, there is no distension, no rigidity, and no guarding. CA125 was done, that was 100. On ultrasound, there was a 8 centimeter cyst in the right ovary. It was a ground glass appearance with minimal pericystic flow. And left ovary and uterus was normal. So how do we manage her? Go for medical or surgical? Dr. Garima?
So this is a patient with 8 centimeter endometriotic cyst. So anything which is more than 5 centimeter is basically recommended that surgery should be the option. She's come to emergency with severe pain. So in my opinion, surgical option is best for her because if she's coming in emergency with such a huge endometriotic cyst, which is more than 5 centimeter, 8 centimeter mass, it should be surgically operative. So laparoscopic cystectomy would be the best option for her.
Okay, fine. This is a large endometriotic cyst, 8 centimeter. We have decided the laparoscopy cystectomy. So how will you counsel this patient? Dr. Manjusha? Is she there?
She's there. I mean,
She there?
she's, yeah. In the list, she is there.
Okay, so Dr. Rupali, can you take the question, please?
Yeah. Can you just repeat the question?
We have this is a 19-year-old girl. She has an endometriotic cyst 8 centimeter. So we have decided the laparoscopy cystectomy. So how will you counsel the patient? What are the concerns before we are doing the cystectomy?
So one of the major concerns is, when you tell a surgery to a young girl, they themselves get very scared. They have to be very positively counseled that this patient who has an 8 centimeter cyst, the best possible option would be going in for a laparoscopy, and the surgery, a cystectomy, a good clean cystectomy, which should be possible in this case, since it's an isolated, looks like a single big endometrioma. Talking of medical therapy, we will not have much of a choice here, but yes, she can undergo a laparoscopy and follow up later on and be symptom free for quite some time. A laparoscopy will also help us to fulgurate the accessory lesions in case there are other lesions along with the main lesion which is not being diagnosed in the ultrasound. That advantage will also be told to her. And cystectomy would be the way forward, which I feel in this patient.
Yeah. Dr. Piki, any other concern we have to tell to the patient?
I will take some time and counsel her and her parents that this is going to be always there. This is not a disease which is going to be okay right now. And what are the consequences? She may have difficulty. She may have a reduced ovarian reserve. And when she is trying to conceive, then there may be problems, because if the mass is pressing against the follicles, that reduces. And after surgery, there are chances that recurrence will be there. And she may be needing more surgeries later on. So it is best if possible, because in this patient, I think surgery is justified. And I feel it is not the size, but the patient's symptomatology, which is very important. If somehow we can reduce the pain, and I will definitely try to avoid surgery in young girls, adolescent girls, because this is going to happen again and again. And every time we do surgery, more additions are there. Ovarian reserve is going to fall down. So all those things are there. And in fact, I will tell her that she should complete her studies, get married fast, and try for conception. And if ovarian reserve is very low, then then I will tell her to go for freezing of eggs, fertility preservation also. So all those things, and she has to be continuously on medications.
Yes.
Medications, she has to be active, exercise, and through, like we discussed in the previous case, all those things need to be told. And subsequent surgeries are going to be more difficult because of additions. And if the size is 8 centimeters and 19 years, as sir had already said, this is severe endometriosis. Depending on what else we get, more additions, DIE, stage 3 or 4, the chances of recurrence will be significantly more. So now comes the role of post-op therapy also.
Yes. So operative laparoscopy is a second line treatment, especially in the adolescent, and it is indicated only when the patient has a severe pain indicating deep infiltrating endometriosis or size of endometrioma is more than 5 centimeter. And surgery has to be done by the experienced surgeon, and risk of loss of ovarian reserve as well as recurrence has to be explained. This is very important for the patient. Now the post-treatment follow-up, Dr. Sonika. Is she there? Dr. Garima, you can take the question, please.
So for so it's operative post treatment follow up is very important in these cases, because it, as ma'am was saying, it will reoccur. So suppressants in the form of hormonal post after operation, hormonal suppression is important. The progesterones like Dynogest are very effective after surgery. If you continue them, then the endometriosis associated pain also decreases, and also the chances of recurrence are less. So progestins like the Dynogest should be used as a first line of medication in patients after the treatment, that is your surgical treatment. It's very important that they should be emphasized that the post treatment follow up is important. They should not once a surgery is done, they should come back to you again and they should continue the medication, because it's a chronic illness. It can reoccur, and again she may land up in the same situation. So post operative counseling and treatment plays a very important role in these young girls. And in my opinion, the Dynogest, the progesterones, the progestin is the best treatment that should be advised. The secondly, or we can use hormonal combined oral contraceptive or the medroxyprogesterone acetate also.
This is very correctly said, because the first line of indication is to prevent the recurrence, and we can give oral drugs like Dynogest and oral contraceptive pills. Now come to the Dynogest. It is safe or effective with the adolescent endometriosis.
Dr. Parul, LNG IUS can also be given.
In adolescent unmarried female?
Not in adolescent.
Not in adolescent.
Or if she's sexually active.
Then we will prefer the
Children are coming who are
first.
sexually active, then
we can have it. Now this question can be taken by Dr. Shaida. I mean, who? Dr. Rupali, please, you can take.
All right. So, talking about the safety of Dynogest, yes, it is known to be safe even in adolescents, and you can give it. Indeed, I have had fewer patients where I gave Dynogest in small size cysts. Small would mean say around 2.5 centimeter cyst, and actually after a follow up, although a regular follow up needs to be maintained, maybe an annual one, after regular follow up, the cysts almost completely disappeared. So the patients were also very happy, and I was also happier that at the younger age, where the cysts are smaller in size, they can be managed on medical means rather than taking them up for surgery. So very safe drugs,
Yeah, so it's
Dynogest, and they
and
just need an annual follow up, not too much. Yeah.
yeah, as a Dynogest mode of action is at central effect, it can inhibit the gonadotropin secretion, therefore leads to decreased estrogen levels and inhibits the ovulation. And at the endometrial tissue, it's anti-proliferative, anti-inflammatory, and anti-angiogenic, and a desensitization of the endometrial tissue. So this is a study which shows that there's decrease in size by 25% to 85% of the cases, and there is also significant decrease in pain. So apart from the side effects like bloating, weight gain, and menstrual irregularity, the most important is, especially in the adolescent age group, there is an associated decrease in the lumbar bone marrow density.
Yes.
So this study highlights the need for tailored treatment in this population, taking into account the expected efficacy in endometriosis associated pain and individuals risk factors for osteoporosis. So we have to be very cautious when we are using a Dynogest, especially in the adolescent age group, because there is an associated decrease in the bone marrow density in these patients.
Even in the later on age group, addition of vitamin D as well as an oral calcium is a good idea,
Yeah.
which because it's usually given for long. It's never given for like a month or so. It's usually
Yes,
given
yes.
for at least a year or 2 years, like that. Yeah.
That's what I felt and said earlier on also. We have to give Dynogest for a long time. So it is better to start them on calcium and vitamin D, just like GNR.
Yes, yes.
Yeah.
One more thing I would like to add on, as that when patient is on Dynogest for prolonged intervals, we should do LFT every 3 months at least, because it is known to have this thing. And why Dynogest scores over E+P in adolescent girls is because it does not cause epiphyseal fusion as the estrogen does. So it's friendly even for the girls who are still attaining the height.
So less than 17, 18 years, when they have not attained full bone mass and their bones are still developing, estrogens need to be avoided, and progestogens are the first therapy. So Dr.
And the
Manju,
best way to assess is that we calculate the mid-parental height. If the girl has not attained mid-parental height, we should really be very, very skeptical about giving this thing. And calculating it is very simple. You take the average of the height of both parents and subtract 6.5 centimeters. That is the MPH for girls. So we have to see if the girl has not attained the height. We can, the girls usually understand this. And they are all Google savvy. They come back and say that why don't you give me E+P because I'll have better cycle control, and then we can tell them that you have not attained mid-parental height. So that's why this is a small cyclical irregularity is a small price to pay for maybe half a centimeter of height which you may gain. So that really goes well with the girls. Yeah.
Okay, fine, nice. So will you prefer surgery for the pain management, Dr. Piki?
Parul, sorry, can I just interrupt? We are little running late. Just
I just
because
want
we
to
have
take
another
one.
panel for
I think Dr.
infertility.
Parul, you see, read out the slides and
So I can read out the slide, please.
Yes.
So we have a role of, okay. So I'm not asking the question. So we have a role of surgery, but obviously it's a second line treatment. When the medical management fails, then we go for the surgery to reduce the endometriosis associated pain. And if we are doing the surgery, obviously the clinician consider excision instead of ablation. And there's also a role of Luna or P-sacral nerve ablation, because it's peripheral nerves are underlying cause of endometriosis. So the RCTs which show the Luna showed that this technique did not offer any additional benefit, but PSN, that a P-sacral nerve ablation, have a better improvement of dysmenorrhea, pelvic pain, and quality of life compared to laparoscopy surgery only, and it acts as an adjunct to the conventional laparoscopy surgery, but it should requires a high degree of skill and associated with the increased risk of adverse effects like intraoperative bleeding, post-operative constipation, urinary urgency, and a painless first stage labor. And most important, is there any role of fertility preservation, because patient is a young girl, 19 years, having endometriotic cyst, 8 centimeters. So she has a higher chance of recurrence. So we can advise a patient for the fertility preservation, egg preservation, but we have to tell the pros and cons of fertility preservation also, because the patient has to afford the cost of the oocyte freezing every year. Then this can be this step-by-step multi-mode treatment of strategies of the pain. This can be taken up by Soumya.
But
Get wind up then. So this we explained diagnosis of endometriosis, treatment of endometriosis according to ASHA guidelines. So thank you.
Thank you very much. Thank you, Dr. Soumya and Dr. Parul. It was an excellent panel discussion. So thank you very much. Now we move on to our next panel, which is actually with an infertility society. You know, that's another very interesting. And we have two moderators. One is Dr. Shikha. She has joined, she is a chapter secretary of Northeast chapter. So can we have a second panel presentation? Can I have her CV, please? And also with her is Dr. Sabina. So can I have CV of Dr. Shikha, please, first? Yeah.
Yes, ma'am.
So Dr. Shikha is a secretary of IFS Northeast chapter, and she has been the winner of ISAR SRM National Quiz. She has co-authored paper awarded as the first runner-up for FOXY, and she has been, I think you did a DNB from Delhi, isn't it? The FNB. Is that Shikha?
And I did my FNB from Kolkata, IRM Kolkata. I did my PG from AIIMS Delhi.
From here, yeah. So presently you are a consultant at W Pratiksha Hospital, Guwahati. So welcome, Dr. Shikha. We have second slide, please, Dr. Sabina. She is also co-convener of, next slide, please, co-convener of SIG Endometriosis. And currently she is working as a consultant at Mata Chanandevi with Katie Nair, sir. Can we move the next slide? Can we move it to the next one?
Ma'am, I'm unable to change the slide.
I'll share the screen, ma'am.
Yeah.
Yes.
Yeah, so just go back once, yes. And she is FNB reproductive medicine from Sir Gangaram Hospital and also MRCOG UK. And presently she is consultant reproductive medicine, Akansha IVF Center, and very active member of SIG Endometriosis. So over to both of you, Dr. Sabina and Dr. Shikha.
Okay, thank you, ma'am, for your kind words. Firstly, as Secretary of Northeast Chapter, I would like to extend my gratitude to Dr. Pankaj Talwar, sir, and Dr. Shweta Mittal, ma'am, for giving me this opportunity to be a part of this webinar. And I would also like to thank Dr. Shweta Gupta, ma'am, for your guidance. So the topic of today's panel is Management of Endometriosis with Infertility, a case-based panel discussion. And I will be joined by Dr. Sabina Singh, who will be my co-moderator. So we have a total of 7 panelists. I welcome all the panelists. Dr. Leena Yadav. Ma'am is a principal consultant of IVF at Max Healthcare. She has done her fellowship in reproductive medicine from Gujarat and her diploma in reproductive medicine from Germany in 2021. Dr. Johan, unfortunately, sir had to leave for some emergency, so he will not be joining us. Dr. Johnson Bagra, he is a gynae laparoscopic surgeon from Arunachal Pradesh. He is the director of Niba Hospital IVF Center, and he is an advanced lap gynae surgeon with special interest in endometriosis
first to start IVF center in Arunachal Pradesh. So this, I think the slides are not moving.
I'll share.
Yes, just.
Yeah, no?
Yeah, okay, yeah. So Dr. Kalpana Jain, she is an IVF consultant at Birla Fertility in Guwahati. She has done her fellowship from Vapi, Gujarat, and she has around 10 years of experience. She's a former consultant, IVF consultant at Akansha Hospital, Guwahati. Dr. Parisuddha Rao, he has done his DGO MS and MCH in reproductive medicine from CMC Vellore, and he was the best outgoing gold medalist. He's a consultant at Makunda Christian Leprosy and General Hospital at Karimganj, Assam. Dr. Battiston de Cruz Vanba, he has done his fellowship in reproductive medicine from CMC Vellore. He's a consultant at Macarius Medical Center, Mairang at Manda Clinic, Shillong. Dr. Mansi Jain, she has done her diploma in clinical ART and fellowship in reproductive medicine from Singapore. She's a consultant reproductive medicine and gynae endoscopic surgeon at KJ IVF and Laparoscopy Center, Delhi. She's also co-convener of endoscopy and executive member of IFS. So we have a total of 3 cases. So let's see how much the time permits and how much we can cover. So coming to the first case, a 26-year-old lady with primary infertility, married for 2.5 years. She has regular menstrual cycles with moderate dysmenorrhea. On examination, tender nodular POD. Transvaginal sonography shows a bulky uterus with 4 centimeter right ovarian endometrioma with 5 to 6 central follicles in each ovary. Hysterosalpingography is normal. AMH is 2.3 nanogram per ml, and husband semen analysis is also normal. So how will you manage this case? Dr. Leena, ma'am.
So hello, everyone. Thank you for involving me in this webinar. Am I audible?
Yes, ma'am. Yes.
Okay. So since she's a young girl and
Ma'am, you're not audible now.
Ma'am, please unmute.
am I audible now?
Yes.
Now you're audible, ma'am. Yeah.
Okay. So since she's a young girl and she has an infertility only of 2.5 years, which is not much. Her AMH is good, and the husband's semen analysis is also good. I would like to give her a trial of IUI cycles first, but not straightly involving her for IVF. But before taking her for IUI, I would like to do a diagnostic laparoscopy for her to assess whether her tubes are open or not. If her tubes are open and there is not much of the distortion of the tubo-ovarian anatomy, then the first line of management for this patient would be doing an IUI.
Yes, ma'am, rightly said. So the answer is we'll go ahead with the laparoscopy first because she has got moderate dysmenorrhea also. So in laparoscopy, we will remove the cyst and that will take care of the...
Yeah, so since the cyst is on the smaller side, less than 5 centimeters, it would not be a good idea to remove the cyst because that would definitely put some of her antral follicles also at the stake. That would lower down her AMH. So we can keep the cyst since it is a small cyst. Yes. Do a diagnostic laparoscopy. If there are subendometriotic spots, we can definitely fulgurate them. And then if the tubo-ovarian anatomy is fine, the tubes are open, we can straight away take her for IUI.
I actually beg to differ here. So this patient, I think I'm going to counsel her. The first option I would say would be to go for laparoscopy, and I don't believe in doing diagnostic laparoscopy only. It has to be a cystectomy, and once you've made the choice that you want to take her up for an operative procedure, you might as well remove as much of the disease as possible. It is already a 4 centimeter endometrioma. You've already made that diagnosis on TVS. So she requires a cystectomy. She's already into grade 3 endometriosis, might be even worse. You will see that when you go inside. So you correct the tubo-ovarian relationship, do as much as correction as possible, and then give her the option of going into IUI immediately the next cycle after your laparoscopic surgery. So I think that is what I would like to do for her.
Yeah, I think because she's having the main symptoms is she's having around moderate dysmenorrhea. Na? So going ahead with laparoscopy is mainly for the pain. And obviously it will be beneficial for the tubes assessment also because her HSG is already normal. So we are doing a laparoscopy mainly for the pain, and it will go like we can look at other things also, assess her tubes also. So decision for a lap surgery was taken. She underwent laparoscopic ovarian cystectomy, adhesive lysis, and ablation of the superficial peritoneal deposits. And both the tubes are patent. So anyone who would do a cyst drainage and coagulation, Dr. Johnson Bagra?
I would rather not go for cyst drainage and coagulation. I would rather go for directly cystectomy. But since the case did not mention whether she had dyspareunia or not, just doing laparoscopy for cystectomy ideally would not be good actually, because if she has dyspareunia or moderate dysmenorrhea, doing laparoscopy. Can you hear me?
Yes, yes, yes.
Doing laparoscopy would be to remove as much as disease as much as possible, because it is not just the cyst which is actually causing pain. There must be some other diseases, other implants, endometrial implants, which must be causing the pain. Just to look all the other factors like tubal and other ovary and peritoneal deposits and all has to be cleared if we are planning to do a laparoscopy. After that, after doing cystectomy, then she can plan a natural pregnancy, or we can stimulate her by giving ovulation induction drugs, or
yeah, we'll be coming to
IUI.
that. Yeah. So before going ahead with laparoscopy, is there any role of medical management, Dr. Kalpana Jain? Hello, Dr. Kalpana, are you there? Dr. Kalpana, am I audible?
She's there.
So, Dr. Battiston, would you like to take up this question? Any role of medical management?
Yeah, so I don't think there's any role of medical management. The case clearly says that she's been married for 2.5 years and she's trying for pregnancy. So I will still agree that we go ahead first with the laparoscopy, clear out the disease, stage the patient, send the tissue for histopathology examination and reporting, and be sure with what we are doing ahead after the staging and histopathology report.
Yeah. So even the evidence says that medical management has no role when the patient is trying to conceive. So, okay. So, and Cochrane review says that laparoscopic excision versus ablation. So excision is always better because the subsequent chances of a natural spontaneous pregnancy rate is also higher in patients with documented prior subfertility, and resection was clearly superior. Also, excisional surgery was associated with a reduced rate of recurrence and superior improvement in pain. So further management, I think we have already discussed that it is better to go ahead with IUI, ovulation induction and IUI in this case. Anybody who would like to give her any hormonal adjuvant treatment post-operatively? Dr. Rao?
So basically here the main complaint with the couple is the infertility. So when you're targeting post-operative adjuvant means it's related to fertility. So there is no role of pain management or some sort of suppressive treatment post-operatively. So immediately going ahead with either IUI or based on stage of the disease or directly IVF. So that would be the preferable management.
Right. So I think there is some problem with screen sharing. Okay, so ASHRAE Guidelines 2022, they concluded that in stage 1 and 2 endometriosis, clinicians may perform IUI with ovarian stimulation instead of expectant management or IUI alone, as it increases the pregnancy rates. And although the value of IUI in infertile women in stage 3 and 4 endometriosis with tubal patency is uncertain, the use of IUI with ovarian stimulation could be considered. Dr. Sabina, I think there is some problem with slide sharing. Can you share
I'll
it?
share the slide. Okay. For the next case also. Can I share?
Yeah, please share. So this patient conceived in the second cycle of IUI and she was relieved of her menstrual pain also. So the case 2 will be taken by Dr. Sabina.
I'm also not able to share. Rahul, can you share the slide?
Okay, ma'am.
Dr. Sabina, it's working now. You can continue, I think.
Okay. Okay, can we have case number 2?
Yes, there.
Can we make it full screen? Yeah, so after the first case, the next case is she is 33 years old lady, married for 8 years, and she is a case of primary infertility. She has already underwent one laparoscopy for left ovarian endometrioma. It was around 7 years back. At that time, it was around 6 centimeter left side ovarian endometrioma was there, and it was removed. But again, when she came back, again there was a left ovarian endometrioma at around 4 centimeter in size, and there was a right ovarian endometrioma 2.5 centimeter in size. Now we did the HSG was already done for this patient, which was normal. And the husband semen analysis, there was odds that it was 7 millions, 20% motility with 8% rapidly progressive and 2% normal forms. Her AMH was 1.2 nanogram per ml. Next slide, please. So, Dr. Johnson, how will you further manage this patient?
Since she had already undergone laparoscopic cystectomy for ovarian endometrioma 7 or 8 years back, and she has a long history of infertility. So ideally, this patient should be stimulated for controlled ovarian stimulation and directly go for IVF, ICSI, with ICSI.
Okay. Dr. Battiston, any other opinion you have? Any role of repeat laparoscopy you would like to do in this case?
So she's a case of recurrent endometrioma. So I would also agree and go directly for IVF. But before doing an IVF, I would do a scan myself, TVS scan myself, and check the accessibility of the follicles in relation to the cyst. If there is any difficulty in accessibility during the oocyte pickup, I may think of this aspiration or a repeat laparoscopy where I will just do a deroofing and cyst aspiration, and that's all.
So basically, in the cases where there is if there is any dysmenorrhea or inaccessibility to the follicles prior to the ART, then you can consider the repeat aspiration or laparoscopy, right?
Yes, ma'am. Yes.
Okay. Dr. Mansi? Any role of repeat?
Yes, ma'am. I would actually tackle it. Ma'am, I feel repeat laparoscopy is something we really have to be, absolutely sure why exactly are we looking for it. If we are going for ART, there is absolutely no role of laparoscopy here. I would take it as it will be better to retrieve the follicles, and if we do have endometriomas, it might be a good option to suppress it. You do the pickup first, suppress it for 2 or 3 cycles with the agonist, and then go for a FET cycle. As far as the approachability and difficulty in retrieval is considered, it's something which I have not really encountered in my practice, because it's very easy. We all are very well trained in doing pickups and all, so there are chances of avoiding a good mapping of the endometrioma before taking up her up for the pickup. Noting it down in the IVF file also that there is an endometrioma, so you are already careful about not to prick it. And in case if you do accidentally even prick it, it's I would not aspirate the whole thing out. I would immediately either change my needle or just give it a thorough wash and cover it up with a good antibiotic cover post-op.
Okay, right.
So I think this approach will be better than take her up again for a repeat laparoscopy, because it will definitely compromise her reserve.
Okay, right. So, Dr. Rao?
Yes, please.
Any role of GnRH analogs in this case prior if you are taking this patient for IVF?
So the question is probably based on what type of protocol we are going to use. That Probably that will be the right question if I'm not wrong. That is the thing you want to ask?
Yes,
So in this case, AMH is 1.2 and there is, I didn't see how many antral count are there actually. So that would have given me the right option. But well, since it is not hyperresponder, I would like to prefer go for GnRH long protocol. So, but the recent Cochrane says there is no difference between the long suppression versus anti protocols. But so with personal experience, we still go ahead with GnRH long protocol.
All right.
Since it is not high risk for early onset of OHSS.
Dr. Leena?
I completely agree with him. GnRH long protocol is a better option. And I also completely agree with Dr. Mansi that doing a repeat laparoscopy doesn't make any sense.
So
Because she's also
there are any indication in which you will do in the repeat laparoscopy? If even this is the case, any other indications in which we can consider the repeat laparoscopy?
if the accessibility of the follicles is very difficult. If the accessibility of the follicles is very difficult, if she has a lot of dysmenorrhea, then a repeat laparoscopy can be considered.
Dr. Mansi, any other indication?
Pain. I would say pain, and how is it affecting her daily life if she is really having that much dysmenorrhea and she's tried medical treatment also prior, or I mean at present she's trying for a pregnancy. But yeah, I think more than the accessibility, I mean I'm speaking truly out of my practice. So more than the accessibility, I think it's pain guided, and it's her basic desire if she wants to get rid of the disease.
Dr. Kalpana? Dr. Kalpana,
I completely agree with this. Repeat laparoscopy only if it is not the follicles are not accessible and the pain. Otherwise, no, not required.
Can we have next slide? Can we have next slide? Yes, next. 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 So yes, these are the cases which are in the literature. It has been given if there is rapid growth in size of endometriotic cyst, or if there are any suspicion features we are going to see on the ultrasound or MRI. Inability to assess the follicles, as you have already mentioned. Excessive pain, Dr. Mansi, Dr. Leena has already mentioned this. And if there is risk of spontaneous cyst rupture, then yes, we can consider. Next slide, please. So yes, surgery for endometrioma prior to ART can be considered to improve the endometriosis associated pain or accessibility to the follicles. Next slide, please. Okay, this already has been discussed. I think Dr. Shikha and Dr. Kuldeep sir has also been mentioned. Will you consider aspiration of cyst before IVF? Because see, already the laparoscopy has been done for this patient, cystectomy has been done. Now this patient we have taken for IVF, we have taken for the pickup. So will you consider any aspiration in this case? Dr. Johnson?
Madam, frankly, I don't have any experience with this cyst aspiration during pickup. So it would be better I don't answer this.
Okay. Dr. Mansi, are you using
lead
ethanol
to
sclerotherapy or something like this?
Ma'am, ethanol sclerotherapy, I have not been doing it in my practice, but I was just seeing the research work already done on it. Actually, theoretically, it should not be causing any harm to the ovarian reserve, but as if we look at the evidence, it does not really have any added advantage as far as the pregnancy rates or the recurrence or the impact on AMH or ovarian reserve is concerned. So I don't use it in my practice. And I mean, as far as the evidence is considered, I don't think it has any added advantage. So,
Dr. Battiston?
Ma'am, I don't do cyst aspiration before IVF. So
Okay, right. Dr. Rao?
Personally, evidence says there's no much of use.
Yes. And Dr. Leena, Dr. Kalpana, are you people using any of these
no.
ethnosclerosis?
So we don't do cyst aspiration, and obviously there is no added advantage.
And if it on a pregnancy rate or anything, yeah, even me.
Yes. So next slide, please. Next slide. So yes, neither surgical resection nor aspiration followed by ethnosclerotherapy of endometrioma give any beneficial effect on IVF outcomes. Next slide, please. Now, okay, we all now agree that this patient was taken for IVF, and we have started with the stimulation protocol. So the basic question, which protocol you people are using? Dr. Leena.
So if the AMH is on the higher side, then definitely we can go for an antagonist protocol. But if she has an AMH which is really low, less than 1.5, we can also use long agonist protocol as we mentioned earlier.
Okay. Dr. Kalpana?
Since the AMH is on the lower side, we can go for long agonist protocol, otherwise antagonist protocol.
Okay, right. Dr. Johnson, any other opinion you have?
Only antagonist protocol I use.
Antagonist. Okay. Dr. Battiston?
For this case, I will go for a long agonist protocol.
Long agonist. So basically, it's a long agonist or prolonged down regulation to people are telling it is a long agonist, right?
It is a long agonist.
Okay. Dr. Rao?
Yes, it's a long agonist protocol and targeting the fresh embryo transfer.
All right. So, Dr. Mansi, any different opinion you are having or you're saying?
Ma'am, like I said, in this case, the AMH was 1.2. The AFC wasn't mentioned, but in this kind of a case, I would prefer to go with an anti protocol, then go for suppression for 2 to 3 cycles, and then go for
then the frozen embryo transfer. All right.
Yeah.
Next slide. So yes, following consideration, as Dr. Kuldeep also mentioned, that age of the patient, duration of infertility, ovarian reserve, stage of endometriosis, and other confounding factors has to be considered. Next slide, please. So according to the HT guidelines also, a specific protocol for ART in women with endometriosis cannot be recommended. Both antagonist or agonist protocol can be offered based on the patient's and physician preferences. But yes, patient should be very much reassured that regarding the safety of ART, since the recurrences rate are not increased compared with those women who are not going on ART. Next slide, please. Next slide. So this is the same. So yes, at the end, the take-home message generally is that the GRH antagonist protocol is suitable for both extremities of ovarian reserve in these endometriosis cases. It is good choice for poor responder, patient with poor ovarian reserve, and the endometrioma or after a surgical resection. Next slide, please. Next slide. So this has already been discussed. So, Dr. Mansi, what problems do you anticipate during this, if you are doing the pickup of this patient with endometrioma, what problems can you anticipate?
Oh, ma'am, so usually if it's a grade 3, grade 4 endometriosis, mostly the ovaries are usually adherent. So at times they're completely posterior. So accessibility of the follicles might be an issue in these cases. Accidentally, you may puncture the endometrioma and that might lead to an abscess.
Yes,
so these are the things that you encounter.
Dr. Battiston, any other opinion?
We may puncture the endometriotic cyst.
Yes.
So we very wary about that, where it is. So I would probably go first to the ovary without the endometrioma, complete that, and then go to the ovary with the endometrioma. So even if we puncture, we won't compromise the other oocytes that have been collected.
Yes. Dr. Rao?
Yes, same like Dr. Batson.
Okay. So yes, difficulty to assess the follicles as already told by panelists, and there can be infidem puncture of cyst with risk of spill, contamination of follicular fluid with the endometriotic fluid, and ovaries stuck behind the uterus can also be one of the challenge. Next slide, please. So Dr. Kalpana, what precautions will you take during the pickup in this case? Any other preparations you have to make?
Antibiotic prophylaxis, and I would prefer to give post-op antibiotics also, considering if accidentally, if the chocolate cyst has been ruptured. So I would give full coverage of antibiotics in this case.
So basically antibiotic coverage we give in all the cases, but in this case specifically we have to take care, and even if there is any puncture, and we have to give the post-operative. Is it you are saying, Dr. Kalpana? Yeah. Okay. Dr. Johnson?
Yes, ma'am.
Any other precaution you will be taking?
Same as others are taking. Thank you. Ma'am, I have to leave. Thank you, ma'am.
Okay, okay. Thank you, sir. Thank you for joining. Okay, Dr. Leena?
So I would also be doing the same thing. I would be giving antibiotics to the patient. And if we have done the cyst aspirate, the cyst is ruptured, after doing the complete pickup with the needle which is left behind, we should try to aspirate that fluid if we can.
Yes.
Because otherwise it's going to create a havoc inside.
Okay. So can we have next slide? So avoid puncturing the endometrioma, antibiotic covers, pre-operative counseling, and this is as in the all the cases, and post-operative regarding the symptoms of any infection, and to report as soon as possible in that case. Next slide, please. So during pickup, the endometrioma accidentally got punctured. Will you continue to aspirate all the chocolate material or move on with the pickup? Dr. Mansi?
Ma'am, I already said I would just no, I would not continue to aspirate all of it. I'll take out my needle, maybe replace the needle, or I'll just give it a thorough flush and then move on to the next follicle. Try to avoid the endometrioma.
Yes. Next slide, please. So yes, will accident puncture of endometriotic cyst during oocyte retrieval affect the embryo quality or pregnancy rates? Dr. Rao?
Probably when you're rupturing that cyst, that follicle might get affected, not all the follicles, because per se it's ultimate. Finally, the thing which should affects our result is the number of oocytes you get. So rather than
the quality.
Yeah.
Next slide, please. So yes, there is no conclusive evidence, but yes, the number of oocyte retrieved, they definitely have been affected. Next slide, please. Exposure of oocytes to endometrioma fluid does not alter the fertilization of or early embryo development. Next slide. So yes, this patient underwent antagonist protocol only. We were able to retrieve 8 eggs in this case. 5 blasts were formed, all were frozen. We down-regulated with 3 doses of GnRH agonist. And then the frozen embryo transfer was done after 3 months. 2 blasts were transferred but failed in subsequent cycle. She got pregnant. So, so this was the case. Thank you so much. Next case will be done by Dr. Shikha.
It's a short case. Do we have time for it? Just 5 more minutes, I think it will take. Next slide. Okay, it's a 38-year-old lady, married for 12 years with primary infertility. She underwent a laparoscopy for endometrioma 10 years back and laparotomy for endometriosis 3 years back. On sonography, there's a bulky uterus with a 2 centimeter right ovarian endometrioma with 4 antral follicles. Left ovary is small with no follicles. And left-sided, there is a large hydrosalpinx. On HSA, there is OAT, AMH is 0.4 nanogram per ml. So how will you go ahead with this, Dr. Battiston? Next slide.
I have to probably counsel the patient properly, telling her about her low AMH, decreased, the diminished ovarian reserve, and with the involvement of the hydrosalpinx on the left side. So we'll have to tell her that the doing a delinking or a self-injectomy, it will not be a very easy case for her because she's already undergone 2 previous surgeries, laparotomy in the second surgery, I think, and the recurrent endometriosis will always be there. So with all these aspects taken into consideration and after counseling the patient, the decision needs to be taken along with the patient's informed consent.
So you will, after laparoscopy, you would go ahead with IVF?
Yeah, with IVF.
Can we have the next slide, please? Yeah. So, Dr. Mansi, after laparoscopy, how would you like to go? Like with donor egg, IVF or self?
Ma'am, actually, if there are 4 AFCs, firstly, I'm going to sit with her and counsel her and explain to her the complexities of the situation. She is a very low reserve patient. I'm not going to straight away offer a donor oocyte. I will try working on an optimization of the ovarian, controlled ovarian stimulation. So I will prefer to do OPO first. If at all we have to use our eggs, I will directly not go over to donor oocytes. So that will be number 1. Try get as many as oocytes as possible, explaining her the chances of cancellation. In case if we are able to get good quality oocytes, good quality embryos, so then I will proceed with the laparoscopy, do clipping, and then but once we have put in the scope, I think it's better to do maximum correction as possible. So again, we'll have to counsel her, look, we're going to do the surgery and it will definitely decrease your reserve further.
So, and after that, go for a frozen cycle. So a lot of counseling has to go into this. The patient's desires and aspirations also have to be kept in mind. So all these options, definitely maybe sometime in the future, the possibility of going for donor eggs has to be discussed. But I will definitely give her the option of using her eggs at least once.
Anyone would like to add something, Dr. Leena?
So for me, this case is like age is very important. 38 years, laparoscopy already done, laparotomy already done, husband having oligoasthenoteratozoospermia, AMH 0.4. If we are going to stimulate her with her own eggs at this time and fertilize her with a sperm which is already oats, the kind of embryo which we will get with endometriotic disease inside will not be very healthy to be implanted and give her a successful pregnancy. So I would actually, explain her all the odds and then probably take her directly for donor eggs, because she does not have time at 38 years of age to, be doing all this.
Exactly. So detailed counseling has to go in this, and the patient has to be explained the success rates with both self-egg IVF and donor oocytes. So obviously the success rate with donor egg will be much higher. And if the patient is still adamant that she wants to go ahead with self-eggs, we can obviously give her there is a good chance.
Yeah, then it's her choice.
Exactly. So, but there are some patients who want to just go ahead with only one IVF. They can afford only one. So in that case, we have to tell them the success rates. In either cases, if we are going ahead with self-egg, we will do a pickup first and then do a laparoscopy. And if we are going ahead with donor eggs, then maybe we can do her laparoscopy first and then make the embryos and transfer. Yeah.
Yes.
Next slide, please. Yeah. So this patient was taken up for laparoscopic tubal clipping or oblique salpingectomy. However, due to frozen pelvis, no attempt was made for salpingectomy, only the clipping was done. And then she underwent IVF. Next slide. So just before concluding, a short word on fertility preservation. So a history of, on a recent paper in RBM Online, they concluded that a history of surgery for ovarian endometriosis was associated with significantly lower oocyte yield. So fertility preservation should be integrated into the endometriosis management and should ideally be made available to everyone before going for surgery, that it should be counseled, especially if the, next slide, please. Especially in the subgroup when they have bilateral endometriomas, or in those who are scheduled for surgery for contralateral recurrence after unilateral endometrioma surgery. In those patients, we should particularly counsel them for fertility preservation choice. Yeah. So thank you, everyone.
Thank you.
Yeah, so thank you, Dr. Sabina and Dr. Shikha, Dr. Leena, Dr. Mansi. I think it was an excellent panel discussion, but I think we are running a little late. Any question anyone wants to, or we can wind up then? Dr. Shikha, your team is, Dr. Shikha, are you with us?
Yes, ma'am.
Yeah, so I think they were, your panelists are also getting late. I think it's there. So anything we want to, Mansi, you want to add, or otherwise I think we will wind up. We are already late
No,
by more
ma'am.
than
No, ma'am. I just
45
want
minutes.
to thank you and your entire team for collaborating with us. And I would also like to thank the Northeast chapter. And it's been a great discussion, and it's been a very interactive session. And I really look forward to more such collaborations in the future.
Yeah, so actually it was with endoscopy and also our endometriosis and with Northeast chapter. So thank you, Dr. Shikha and
Thank
Dr.
you, Dr.
Mansi,
Shweta. Thank you so
Dr.
much.
Panara, Dr. Leena,
Thank you.
Dr.
Thank you, ma'am.
Lakshman is also here. Yeah. So I think Sabina, hi, where are you?
बाबा अब निकल रही हूँ.
Okay. So bye. Thank you, everyone. I think
Thank
we'll
you,
close this
everyone. Thank
section.
you.
Bye.
Okay, bye.
Okay.